Dr. Goldberg here, continuing our internal medicine lecture series. Today we're talking about acute pancreatitis. Acute pancreatitis this is a disease entity we see in the hospital quite frequently, as well as the outpatient setting. You need to be familiar with its presentation. Generally, these patients are presenting with acute abdominal pain in the mid-epigastrium, which often will radiate into the back because of the location of the pancreas. Frequently, they have associated with nausea, possibly vomiting, and anorexia with weight loss. Most commonly, we see this setting in the setting of alcoholism, people who abuse alcohol chronically, especially in the VA population. In the community hospital location, frequently it's related to gallbladder disease, passing gallstones, or where gallstone gets caught in the common bile duct, or obviously blocks the pancreatic duct. Passing a stone, or even choledochulolithiasis, where the stones get stuck and need to be removed surgically or with ERCP. If patients don't drink and they don't have gallbladder disease, you have to start thinking about other causes of pancreatitis. These include autoimmune disease, where there's high IgG4 levels. Sometimes lupus patients can have pancreatitis. Patients with rheumatoid disease, such as rheumatoid arthritis, Sjogren's disease, inflammatory bowel disease, and patients with primary sclerosing cholangitis. Look for other causes, however, such as abdominal trauma, medications such as steroids, NSAIDs, diuretics, azathioprine, sulfa. All these drugs can be associated with pancreatitis. Contiguous ulceration of the duodenum can cause inflammation of the pancreas, so that's always on the differential, as well as sometimes viral diseases such as mumps. There are certain bites that are associated with pancreatitis, including scorpion bites and certain poisonous snake bites. And of course, always think about hypercalcemia as a cause of pancreatitis and or hypertriglyceridemia into the thousands. Our patients will have marked amylase and lipase levels. Of course, the lipase has a longer half-life than amylase, will stay elevated longer, but we use these enzymes as markers in the serum to monitor the clinical response to the pancreatitis. The complications of pancreatitis are pretty significant. We can see infections occur in the pancreas, as well as necrosis and pseudocyst formation with phlegmon. Very long healing process in pancreatitis, and even after healing, they'll often have complications of pancreatitis requiring pancreolipase enzyme 15,000 units 3 times a day, and often they'll become diabetic and require insulin for long-term therapy. So NPO, TPN therapy, pain control are all necessary in our patients with acute pancreatitis. Be on the lookout for pancreatitis and be careful with treatment. Surgical treatment is, you have to be a real expert to take care of it surgically if there's complications. And of course, even doing ERCPs can cause pancreatitis themselves, so got to be careful with using the ERCP. So Dr. Goldberg signing off at this time. Thank you.